Greetings, everyone. Thank you for joining us and welcome to today's session. We'll be getting started in just a few moments. While we're waiting, please take a few minutes to just familiarize yourself once more with the Zoom platform. We'll be starting soon. Let's go to the next slide. Well, good morning or good afternoon, everyone. Thank you for joining us. My name is Steve Adelsheim. I work at Stanford at the Center for Youth Mental Health and Wellbeing, and I'm part of the National Network Coordinating Center for the Mhttc Network, and also part of EPINET with their dissemination work group, as well as PEPNET. And I'm really honored to be able to be facilitating and hosting today. And thank you all for being here for this WebCAB focused on the new online outcomes monitoring tool for states and agency administrators working with early psychosis clinics. As we get started, it'd be great to know who you all are who have joined us today and where you're from. So please let us know in the chat what your location is and where you're joining us from. And thank you very much for being here today. Next slide, please. So a couple of housekeeping items as we get going. Please know that everyone is muted who is an attendee and really are unable to share your video at this point. We'd really like people, though, to ask questions and ask for clarification as we do this presentation with you. Please use the question and answer piece down on the bottom of your Zoom screen as well. Feel free also to use the chat box. If you have a comment for the whole group or tech-related issues, we have our team monitoring the chat. So let us know that you need tech support by maybe typing tech support in there so that we'll be able to reach out to you directly. Please know that this session is being recorded and we'll be posting the slide deck to the website for the Mhttc Network as well. Give us a week to complete that task and get that uploaded to you. And if you're attending more than half of today's session, you'll receive an email allowing you to access a certificate of attendance for the session as well. The event is captioned, and if you'd like to view them, click the arrow besides the captioning box at the bottom of your screen and choose Show Subtitles. To change the size of the subtitles, click the arrow next to the box and choose Subtitle Settings, which will then give you options in terms of changing the size of the subtitles as well. Please follow us on social media. You see @Mhttc Network, and please stay in touch throughout the session as well. Let's go to the next slide, please. A quick disclaimer. Just know that this presentation was prepared for the Mhttc Network under a cooperative agreement with Samsa. The opinions that are expressed in the presentation are the views of our speakers and don't reflect the official position of the Department of Health and Human Services or Samsa as well. Next slide, please. Just to be sure that everyone's familiar with the Mhttc network, we want to be sure that you're all aware that the network was established in 2018 and is funded by Samsa and really is focused on providing training and technical assistance to states and treatment providers, really with a focus on developing and strengthening the mental health workforce, helping people and organizations implement effective practices in terms of mental health, disorder prevention, treatment, and recovery services. The network really includes 10 regional centers across the United States, 2 national centers focusing on specific populations, including the National American Indian Alaska Native Center, as well as the National Hispanic and Latino Center. And then, as we mentioned previously, the network coordinating office housed here at Stanford in the School of Medicine as well, which provides leadership, infrastructure, support to the network, including the liaison role with Samsa and coordination of the national projects. Next slide, please. We want to just share with you the values of the Mhttc network. We know that language matters, and we really ask all of our presenters and our audience and our participants to join us in promoting, affirming, respectful, and recovery-oriented language through all of our efforts, through our chat, and through this presentation today as well. So thank you very much. Let's go to the next slide. Okay, I think we're ready to get started. And if we could jump to the next slide now, it's my honor to introduce our first speaker, Thiessen Thomas, who's the Director of the Division of State and Community Systems Development with the Center for Mental Health Services at Samsa. Thiessen in this role manages the staff who oversee the mental health block grants, the protection and advocacy for individuals with mental illness grants, the projects for assistance and transition from homelessness, the PATH grant program as well, and the minority fellowship program grants, additional contracts and grants as well. Let me hand things over to Thiessen, who will get us started with his next slide. Thanks, Thiessen, very much.
Thank you, Stephen, and good morning, everyone. Glad to see all of you joining us this afternoon, or for some of you, the morning. Next slide, please. The Community Mental Health Services Block Grant was authorized by Congress since the 1980s to fund services for adults with serious mental illness and children with serious emotional disturbance. The Mental Health Block Grant Program, which is relatively a small portion of the overall mental health expenditures nationally, has a major impact on grantees, which includes all 50 states, the District of Columbia, Puerto Rico, and the US Virgin Islands, and 6 Pacific jurisdictions we fund. Services that are funded by the block grant include community mental health treatment, co-occurring substance use disorders, evidence-based practices, and an array of supportive services that the states provide. The states uses the mental health block grant funds to service that people that are not only covered under Medicaid, Medicare, and commercial insurances, but the mental health block grant is used for those services that are not covered under these insurances. States also routinely uses the block grant to fund new initiatives. The mental health block grant plays an important role in every state's mental health system. This includes transformation efforts, innovation, and promotes implementation of evidence-based practices. Within this context, Congress authorized a set-aside to be established for the mental health block grant. With the peak of onset of mental health symptoms occurring between the ages of 15 to 25, psychotic disorders such as schizophrenia can derail a person's social, vocational, and academic development and initiate a trajectory of poor outcomes. The longer the duration of untreated psychosis, the poorer the prognosis will be. For many years, Samsa asked states to use the mental health block grant to implement newer evidence-based practices. However, with no new money attached to it, states were reluctant. So the National Institute of Mental Health launched the RACE initiative in 2009, and Samsa started implementing the components of the coordinated specialty care in 2014, with the Congress initially allocating new funds to the existing block grants. Since then, the first episode psychosis program was transferred from a research program to a community-based mental health service. Next slide, please. The statute, the mental health block grant statute, clearly mandate that the set aside funds must be dedicated to those with early serious mental illness, including first episode psychosis. Through the Samsa guidance, we asked states to use the funding to implement models which have demonstrated efficacy, including a range of services and principles identified by the National Institute of Mental Health. Samsa also encouraged states to focus on first episode psychosis rather than just the broad category of early serious mental illness. States were also asked to leverage Medicaid and other funds to support the components of the coordinated specialty care, and Samsa worked with the CMS on this particular initiative. Eventually, Samsa wants states to move their system towards early intervention and or enhance early intervention services that are already implemented. Next slide, please. So I just wanted to show the evolution of the first episode psychosis through the years. Since the clinical trials in 2009 and implementation of first episode psychosis program through the mental health block grant set aside in 2014, and to date to the block grants, Samsa invested more than $660 million to first episode psychosis nationally. For the success of the program, we are all indebted to the NIMH research and dedicated support, and also the Samsa project officers who worked very closely with states implementing the program since 2014. Next slide, please. Approximately 100,000 young adults experience their first episode of psychosis every year in the United States. In 2020, 50 states reported coordinated specialty care data to us. State mental health authorities reported that 18,000 people with an early serious mental illness or first episode psychosis received coordinated specialty care services in Samsa supported programs. We currently have 343 first episode psychosis program throughout the country. Next slide. States embraced the coordinated specialty care wholeheartedly. States do have the most important role in improving their mental health system of care. States understand clearly that providing treatment early is beneficial to the individual and can have cost benefit for the public mental health system overall. The implementation of first episode psychosis nationwide was a concerted effort. Samsa, in partnership, worked with the National Institute of Mental Health, the Assistant Secretary for Planning and Evaluation within the Health and Human within the U.S. Department of Health and Human Services. We worked very closely with the Centers of Medicare and Medicaid Services, and also with the National Association of State Mental Health Program Directors. For last 4 years, the Mental Health Technology Transfer Centers, or the MHTTCs, provided training and technical assistance to states, provided webinars and other resource materials to support the first episode psychosis programs. One of the main focus of Samsa now is to start looking at the fidelity to the model, ensuring the clients who are enrolled in the program have an improved outcome, and to ensure that the first episode psychosis programs have the tools that they need in order to be successful. Today's webinar is to ensure such an effort. So I thank the National Institute of Mental Health for sharing this web-based tool with all the FEP programs. Thanks also to the Mental Health Technology Transfer Centers for hosting this webinar. And on behalf of Samsa, I welcome all of you to this training. Thank you.
Thank you, Thiessen. We really appreciate you getting us started and clarifying the important role of Samsa in leadership of this effort. We're next going to hear from Susan Azrin, the unit chief of the Early Psychosis Prediction and Prevention Research Unit at NIMH, at the Division of Services and Intervention Research, where Dr. Azrin provides leadership for EPINET as the government science officer. Dr. Azrin previously also served as the government project officer for the RAISE ETP study, which was integral in developing the research efforts around coordinated specialty care and the development work in developing the science base around early psychosis support. Thanks, Dr. Azrin, for being here with us. Next slide, please. Perfect.
Thanks so much, Steve, for that introduction. That was lovely. And hello, everyone. Thank you for coming here today to learn more about how the EPINET WebCAB can help ensure that you're providing the best possible care to your clients with early psychosis. And here are my disclosures. So NIMH launched the Recovery After an Initial Schizophrenia Episode, or RAISE, research initiative in 2009 to explore a better way to provide early psychosis care and improve recovery outcomes. Fast forward, RAISE demonstrated that coordinated specialty care for early psychosis is more effective than usual care, and coordinated specialty care, or CSC, is cost-effective and scalable in the US. So the RAISE findings, the mental health block grant set-aside funds for early intervention that Thiessen just discussed, and partnerships with many stakeholder groups and other federal agencies, including our fabulous collaborator, Samsa, together fueled a huge expansion of evidence-based early psychosis treatment programs in the US. So we now have more than 360 publicly funded CSC programs, at least one in every state, with tens of thousands of young people receiving CSC each year. This is truly a science to service success story. So the proliferation of CSC programs and the field's interest in measurement-based early psychosis care created an opportunity. In 2018, NIMH established the Early Psychosis Intervention Network, or EPINET. And here you see the mission of EPINET: to accelerate advances in early psychosis care, recovery outcomes, and scientific discovery. So you may be wondering, what is learning healthcare? Well, learning healthcare is a system of care that aligns evidence-based practice, standardized clinical assessment, medical informatics, large-scale data analysis, and active stakeholder involvement, and the continuous improvement of services and participation in practice-oriented research. In a learning healthcare system, the measurement-based care, that is, measuring the treatment delivered and the outcomes of that care, is key. And I'm proud to say that EPINET is the first large-scale learning healthcare system for people with serious mental illness in the United States. Collaboration among early psychosis care stakeholders is a core principle of EPINET. Individuals with early psychosis, their families, coordinated specialty care programs, and clinicians, state mental health authorities, advocacy organizations, our federal partners, we want to work with you and we need your input. EPINET was designed to be a resource to this entire early psychosis care community. So today you'll hear more about the EPINET Core Assessment Battery, or CAB, which consists of standardized measures to assess key domains of early psychosis, psychopathology, recovery, treatment, and contextual factors. And as the name suggests, the WebCAB is web-based. It's a web-based version of the CAB. It's an online data collection tool that makes it easier for CSE clinicians to use CAB measures and data in their clinical practice. The WebCAB also makes it easier for agencies and state mental health authorities to view and use this data for quality improvement and monitoring purposes. Abram Rosenblatt, who leads the EPINET National Data Coordinating Center at WestStat, will tell you more about the WebCAB and how it can facilitate measurement-based care and support early psychosis, learning health system, quality improvement, and monitoring goals in your own CSE programs. And then we're fortunate to have here today WebCAB users from the state of Virginia. The Virginia State Mental Health Authority has adopted the WebCAB across all of its early psychosis treatment programs. EPINET Steering Committee Co-Chair Howard Goldman will lead a panel discussion with Virginia's Jeff Van Arnhem, Andrew Leonard, and Benjamin Marks, who will share with us their experience using the WebCAB and its data at the program, agency, and state level. In the state of Virginia. So I hope that when you listen to today's speakers, you'll be inspired to consider how WebCAB assessment data can support your CSE, QI, and monitoring activities and help you to efficiently deliver the best possible early psychosis care to clients in your agency and state. And we'd also love to hear from you on how the WebCAB can best meet your needs. So I thank you for your attention and for your commitment to providing the best care possible to people with early psychosis. And I hope you enjoy the webinar. Thanks.
Thanks so much, Susan. So as you suggested, let's hear next from Dr. Abram Rosenblatt, our next speaker. Abram is vice president at WestStat, where he is the sector lead for child welfare, justice, and behavioral health within the behavioral health and health policy practice, and is the principal investigator for EPINET at this point in terms of the Network Data Coordinating Center. And Dr. Rosenblatt's going to talk with us about, utilizing tools to improve clinical care in terms of early psychosis support for clients. So thank you, Dr. Rosenblatt, for being with us today. Next slide.
Thank you very much, Steve, and thank you also, Susan, for your introduction to this webinar. It's really a pleasure to be here with all of you. We're going to talk a bit about we've already heard of the core assessment battery as well as the WebCAB, and as a little special treat toward the end of my presentation, I'm going to show you some just published data that further emphasizes the incredible importance of state mental health authorities in obtaining positive outcomes for persons with first episode psychosis. So if we can go to the next slide, please. You've heard about this both from Thiessen and to some degree from Susan already, but there's been a consistent federal investment in early psychosis, beginning with the NIMH RAISE project all the way up through EPINET in 2019 over the past 11 years. I won't dwell on this because you've heard a bit about it already, but this has been a building of both cumulative practice development and cumulative science, really. Next slide, please. So just a few words about EPINET. There are currently 8 scientific hubs spread out around the country that you can see here, and the National Data Coordinating Center together with the National Institute of Mental Health. We make up EPINET. There are about 101 clinics right now that are part of EPINET across multiple states. Next slide, please. As you heard also from Susan, this is a learning healthcare system approach where data is generated through EPINET and shared with folks and stakeholders external to EPINET, and including researchers, practitioners, clients, and family members. And the idea here is also that there is feedback then back from researchers, practitioners, and clients and family members back to the EPINET into the data generation process. So this is really a iterative, circular kind of way of building services and building data for services rather than a traditional from service to practice one-way kind of development. Next slide, please. There are several EPINET tools that can help support the federal investments in coordinated specialty care. You'll hear about most of them today in detail. There's the EPINET CAB, and this is the common individual level data collection across all of the current EPINET clinics. There's the WebCAB, and this is designed to foster data collection efforts in coordinated specialty care clinics that are not currently funded by NIMH through EPINET. So this is a way of allowing and engaging with clinics outside of EPINET. And then there's the program level CAB, or the PL-CAB for short. And this collects program level data, and that will help us understand the diversity among programs and how program components might interact on client outcomes. So this is a very important way of understanding how programs are structured and what the relationship is between program variables and the kinds of individual level outcomes and variables collected through the CAB or the WebCAB. Next slide, please. So let's talk first about the CAB. Next, please. So the CAB, as I mentioned, is the basis for all our individual level data collection across the EPINET programs. It was designed for a resource that can be reasonably included in data collections within CSE programs. The data can be aggregated into a database that has enough statistical power to draw a lot of potential conclusions and generate new learning. Very importantly, the CAB was developed through a 12-month consensus process by the EPINET Steering Committee. The EPINET Steering Committee is composed of the National Data Coordinating Center, the 8 scientific hubs, and the National Institute of Mental Health. So this represented a really unusual opportunity to get scientific leadership and the clinics that are involved in EPINET input into what would be an ideal core assessment battery for first episode psychosis. Next slide, please. So here are all the CAB domains. There are 21 in total. And they range from basic demographics and background to symptoms, functioning, medications, shared decision-making, substance use, and just highlighting a few as I go through, employment, family involvement. So it's a wide range of functional measures, a wide range of descriptive measures, and some service delivery measures around medication. And there are, again, 21 of them. Next slide, please. And what's very important, and we want you all to be very aware of, is we developed this with NIMH. This is publicly available. Anyone can go ahead to nationalepinet.org, which is the National EPINET website. You can go over, and in a very nicely designed, we think, set of web pages, you can pull up any one of the domains that I just referred to, and you can go ahead and look at, download, use, do whatever you want to do with the measures and use them in your programs or use them in your states. So this is a resource for everybody. Next slide, please. Importantly, we have translated these measures to 7 additional languages. You can download those as well. Again, through the EPINET national website, nationalepinet.org. Next slide, please. Now let's talk a little bit about the WebCAB, and you'll hear more in more detail about the WebCAB from our next speaker, Morale. Next slide, please. So the WebCAB is a way, the CAB is really a way of sharing data and accelerating learning, as I mentioned. Currently, we have the National Data Coordinating Center, the 8 scientific hubs, and we are creating out of that a consolidated data set that has common data and common data elements across those 8 scientific hubs. And we're doing that through our collaboration with the scientific hubs at the National Data Coordinating Center here at WestStep. Next slide, please. So the WebCAB is a way for EPINET affiliated clinics, so clinics that are, again, not funded currently by EPINET for data collection, to be able to participate in this consolidated database, to put data into the National Data Coordinating Center in the consolidated database, and to be able to get a sense of what those clinics look like against the national data collected through EPINET. So we think this is a tremendous opportunity to join the EPINET effort without being a full NIMH-funded partner in it, but you would still be a partner working with us on this. Next slide, please. And states are interested in the WebCAB, and this webinar is really geared in part to states. We have 18 state mental health authorities that are working with CSE clinics funded by the Mental Health Block Grant Set Aside that are interested in adopting the WebCAB that we know of. We hope and assume there are more. Next slide, please. And so this is a little bit of new data. Why is the WebCAB relevant to state mental health authority staff and program administrators? As part of a project we did for Samsa in collaboration with NIMH and ASPE, called the Mental Health Block Grant 10% Set Aside Study, we collected data from state mental health authorities and programs, and we did some analyses, and I'm going to share a couple of those with you right now, just as a sort of teaser. Next slide, please. So when we did this work in 2016, 2019, we did some video conference calls with staff from 22 state mental health authorities. We have client outcome data we collected across 34 early psychosis programs. This publication is just now available online in Psychiatric Services, and Shoma Ghosh is our lead author on that study. Next slide, please. And we asked states, so to get a sense of how we did this, we asked state mental health authorities the following questions, and you got a point for saying yes to any of these. And you can see the criteria about how much state mental health authorities communicate with clinics, how active are state mental health authorities in hiring and training, does the mental health authority determine the model, does it work with clinics for age range determination, does it work with clinics for duration of untreated psychosis eligibility. You can see there's some variation on whether state mental health authorities did these things. Next slide, please. And what we found, which I wouldn't say we were surprised to find, but it's difficult to get these kind of system level variables like state mental health authority participation in coordinated specialty care, to get that to actually relate, to be able to demonstrate relations to client level outcomes. There's a lot of steps between these things and client level outcomes. However, we did see that clients do get better when state mental health authorities are knowledgeable and involved with the early psychosis programs in their state. And these are the 4 measures, which are symptom and functioning and quality of life measures, where we found positive change. And you can see the asterisks denoting where this change was significant. So you can see the Colorado Symptom Index, there is positive significant change, global functioning, and social scale and role scales. Next slide, please. What was also interesting is that there were different perspectives on what the most important measures were, whether you were part of the state mental health authority or whether you were clinical staff. And one of the really great things about the WebCAB is you can select the measures you want to collect. And we did notice during our conversations with state mental health authorities and CSE programs that there were some differences of opinion, and you probably all can get an idea why this may be the case. The state mental health authorities are particularly interested in housing, legal issues, employment, hospitalization, substance use, the kinds of things that really relate to state mental health policy making and financing. And not surprisingly, the clinical staff are really interested in symptoms, quality of life, and functioning, which are the kinds of things they're focused on as they work with individual clients and patients. So from this study, we were able to really demonstrate that state mental health authorities can make a very big difference, can have an influence on the capacity of coordinated specialty care programs to achieve more positive outcomes. And again, if you go to psych services, psychiatric services, you can go ahead and read that study. Next slide, please. And I will pass this on now to Steve to introduce our next speaker.
Thanks so much, Abram. And before we jump into our next speaker, I just want to remind folks to feel comfortable. If you have questions, please put them in the Q&A section so that we can address your questions over the course of time that we're here. Comments, other thoughts, please feel free to use the chat liberally and be able to share your thoughts or other thoughts or questions you have with us. Thank you very much. So next we're going to hear from Mehran Kasanjian, who's been very involved in looking at this work on a broad level with state behavioral health administrators, Samsa and IMH, looking at the expansion of first episode psychosis programs really since 2015. He's developed quite a few of the technical assistance materials, looking at the block grant related issues and how states are using the funds, as well as the use of Medicaid and ensuring culturally competent service provision as well. So Moran, let me turn things over to you for the next component. Thank you very much.
Thank you, Stephen. And next slide, okay. So in this presentation, there's going to be two parts to my little speech here. I'm going to go back and look at that larger scale that Stephen mentioned that I often take while looking at coordinated specialty care. And as part of the work that NRI, where I work, has done for WestStat and for EPINET, we did a snapshot of early psychosis programs. And this was done the end of last year and the beginning of this year. And so as part of this, we surveyed all states and followed by a survey of all CSC programs. And so when we reached out to states, we asked them state level questions about what type of coordinated specialty care programs do you have in your state? What is your relationship with them? What types of measures do you require from them? How do you finance them? And what components do they have, and others program specific questions. And then we went back to the programs and we asked them to confirm or to change and update the data. And so what was exciting about doing this through EPINET is that this was an update of previous snapshots that we had done funded by Samsa in 2016, 17, and 18. And so this is the fourth in a series, and we'll be able to look at some data over time. Next slide, please. And so this covers again the methodology that we followed. And we can see there points 4 and 5 that 46 states responded. And then when we went back to programs to ask them to confirm or correct, 116 programs responded. But between the 46 states and 116 programs, we received information about 153 programs, 153 coordinated specialty care programs throughout the country. Next slide, please. And so we can see here the number of programs has gone up, as the line indicates, and we're going back to 2014. And so that is before the set aside, the mental health block grant set aside. And so we can see the number is starting from quite a low base at just 59 programs, jumping up drastically in 2015 as the set aside kicks in. And the number of coordinated specialty care programs increased each year through 2018. And then we have a gap there of 2 years. And now we stand at 353 programs. And that's a rough estimate. I know we've heard a couple of different estimate for the numbers of coordinated specialty care programs, but it's between, say, 343 and 363. I believe those are the two other figures I heard. Next slide. And some of these, the number formatting got a little bit confused here, but we're looking here at federal investment in early psychosis programs since 2014. And this is similar, although to the slide that Thiessen showed us, but the numbers are a little bit different due to how we're calculating it. And so those are all those numbers at the bottom or along the line are in millions. And so in 2014, there was about $22.9 million. And I believe that is counting just actually as the 5% set aside kicked in for early psychosis programs. And this increases as the 5% set aside becomes a 10% set aside to $45.7 million and moves around at about $50 million until 2018 before increasing to 68.5 million or so in 2018, where it has stayed relatively close since. And Thiessen did show on his slide that it looks like in 2022, this fiscal year that's starting, the number will resume being about 68.5, I believe it looked like. However, in 2021, we can see that there's a massive increase in the amount of funding that was available to coordinated specialty care programs. And some of this had to do with a one-time doubling of the mental health block grant, which therefore doubled the amount available to the set-aside. And some of this had to do with an additional $142.5 million worth of set-aside funds that were provided by the American Rescue Plan. So next slide, please. And it's not just federal funding of coordinated specialty care programs that we have. There's also significant state funding. And I have a feeling that the funds reported here, which come from the snapshots, are a bit of an undercount because not all states responded. But we can see that throughout, since the beginning, states have been putting in their own funds. And this is even more significant when you consider that it's not even across states. It's not 18.2 million divided by 51, say. It's often quite lumpy. Some states are putting in a lot of funds, other states not so many. And for example, we'll be talking later, you'll be hearing from the state of Virginia, and the state of Virginia puts in significant funding. Other states such as Oregon and New York also put in significant funding. Whereas some other states may put in a few $100,000 as opposed to a few $1 million. But this, of course, that can be enough to fund a coordinated specialty care program. And so just want to emphasize that the funding is coming from the certainly the mental health block grant, from other federal sources, as well as from state sources, and in some case, even local sources. Next slide, please. And so then the next, this slide and the next slide are block grant or snapshot data. And want to emphasize here that I know we're seeing slightly different numbers across the slides we're seeing today, and that these numbers are those reported to the snapshot. In most cases, I believe they are probably a bit of an undercount, again, because not all states and not all programs reported these numbers. And in the case of 2017 there, we see what looks like a spike. Most likely that if we had 100% completion of data, that spike would not exist there. And there's no reason to assume that the number of clients served in coordinated specialty care programs hasn't just increased year over year. And of course, again, we have that gap there between 2019 and 2020. So just to be aware there that it's not a totally linear scale. Also wanted to say, though, that from the snapshot, we have some interesting data about the average number of clients served in a coordinated specialty care program, which comes out to about 18 clients on average. And the range across programs is from 4 clients to 89 clients. And so it's a very wide range, which could be due to any number of factors, whether a program is just starting up, where a program is located, what resources the program has for staffing. So I'm showing all of these slides to build up how diverse coordinated specialty care programs are in terms of funding, in terms of clients served, in terms of location and program components. And so next slide, please. And so program structure, what program components are present in coordinated specialty care? Now, as we know, coordinated specialty care requires certain specific components to properly be CSC, and we can see that the vast majority of programs have some of those components. So family education and family support, pharmacotherapy, supported education and employment, and individual CBT and case management, all 90% or more of programs have those components. And then we can see peer support. Over 3/4 of programs have peer support, and over half of programs have co-occurring substance use services, psychoeducation or rec groups, and primary care coordination. And so that's what's very interesting, of course, about coordinated specialty care, is that it is a coordination between different types of care. And again, it is a very diverse type of care. And so measuring outcomes, having standard measures to understand how your coordinated specialty care program or if you work at the state, the coordinated specialty care programs in your state work is difficult. Next slide, please. And there is, of course, geographic diversity in coordinated specialty care programs. And again, just to recognize the different items that have been said today, the way we are counting coordinated specialty care here may be a little bit different than some of the other speakers. All states have early psychosis treatment. And by the way, we counted it in the snapshot, almost all states have at least one coordinated specialty care program. Interestingly, over the last few years, several states have begun to strive to provide coordinated specialty care to all of their counties, to clients in all of their counties. And so there are some early leaders with this. Oregon and New York in particular stand out, but more recently, other states have really started to move in that direction, making coordinated specialty care closer to the treatment as usual for people with early psychosis. And so just to the states that are here in dark green are really the states moving in that direction on this map. And so noticeably recently has been Massachusetts, Colorado, and Washington, who since the last snapshot have really increased the number of programs that they have significantly. And again, hammering home this concept of diversity, CSC programs exist in every setting. There are certainly urban programs, several programs right in the city of New York and in other large urban areas. There are many suburban programs throughout the country. There are rural programs serving smaller towns or less dense populations in the East, say. And there are also programs often called with the term frontier in areas that are much less densely populated, in which one might have to drive an hour or more to get to the nearest town. And so this is, again, an incredible diversity to try to understand. If you're both working at a program, you may be facing a wide variety of challenges. And if you work at a state, it may be difficult to know how to measure the efficacy of coordinated specialty care programs in your state across such diversity. And so next slide, please. One final item I wanted to bring up, although I think Abram covered some of the most important points here, is that CSC programs are already using standardized measures. And we can see here there that the top 4 standardized measures used by CSC programs are those that they identified, that the clinicians identified as being most useful. And so that is perhaps not surprising. But what is interesting and what is heartening is that 3 of these measures there, the modified CSI, the global functioning role, and social scales, are also the measures that Shoma and her team found are linked with SMHAs, with the people at the state, taking an active role in interacting with their programs. And so the programs are already using the measures that have been shown to be linked to your state having a more active role. You should be able to measure then whether or not there are improvements. And so that's exciting, because that means it's you're not necessarily having to start from the base 0. So next slide, please. And so this is where I'll bring it all to a head and change directions in the slides I'm presenting here. We have this tremendous diversity of geography, of geographic extent of where programs are, of the number of people served, which is a significant amount, and program structure. And there's a significant amount of funding for these programs. And whether it's coming from federal funds, such as the Mental Health Block Grant, or if it's coming from states, or increasingly, and hopefully more increasingly over time, from insurance, whether Medicaid or private insurance. But across this diversity, how do we know if CSC programs are performing well? And particularly if you're a state, how do you know if CSC programs are impacting the other priority areas for your state and are they having the impacts that you would like to see? And so how? Next slide, please. Something we've already talked about a little bit today. This is where the WebCAB can really come in and help make a little bit more logical and comprehensible what's going on in CSC programs in your state, if you're from the state, or if you are at a CSC program, help you see across all of your clients how you're doing, and ideally see at a glance maybe what changes you might need to make in a treatment plan. So next slide, please. And some of this at the top, I know Abram has discussed what the WebCAB is. And I'll just add that it's very simple to use. And we'll look at a couple of screenshots of the interface here. But the website is extraordinarily easy. Any of your team members or any of the teams in your state could learn how to use it in a half hour or possibly less. And it allows you to not just enter in data, but also to track clients and to view change over time, and to compare your program's data with data within the larger EPINET consolidated database. And so that's those comparisons and those options for comparison. We'll get into that a little bit more. And if you're wondering, if you're a state and you're wondering, oh, would it be useful for me to see if I could get my programs to be involved in WebCAB, want to add that there's a couple of things to keep in mind. It's not just new clients after a program joins WebCAB who can be in the database, but all previous existing clients within the program who are currently being served by the program can be included into the database. And so you can start to see some of these, you can get baselines that are going back a ways to really understand change over time. Next slide, please. And so these are a couple of screenshots from the WebCAB interface, and we can see that there are two primary tabs. There's the client list on the left and the data entry tab on the right. The client list, as it indicates, is a list of all clients for whom a measure has been entered in, and you can see in the client list the last measure that's completed and what their status is. Are they active or have they been discharged? And in the data entry tab, then you will have a list of all of the measures that your program can enter in. And this is something that will be different between programs and between states. And so, for example, in the state of Virginia, they have elected to use the same set of measures across all of their programs, which allows for better comparison. And so every program in the state of Virginia would see the same set of measures in the data entry tab. And likewise, if you decided to use a specific set of measures across all of your programs, all of the programs in your state would see those measures in the data entry tab. And as we move to the next slide, there's the client summary tab, which if you click on it, you get two primary sections that you can view. One are all of the completed assessments. You can see when the measure was completed, what measure it is. And if you click the completed measure button, you could even download the measure as it looks filled out. And so if you needed a print copy for a file or for some other purpose, you could just get it quite easily there. And then more interestingly, in my mind, is you can see in the client assessment profile, the measures that that a client has been given, has been administered, the score, and then an interpretation of that score. And so this is another feature, I think, of the website that's very useful clinically. You don't have to go looking you don't have to go looking through a manual to understand what does a score mean, particularly if, say, the person who administered the assessment is different from the person who's now viewing the data. So next slide, please. And so I've mentioned already a couple of those clinical benefits of using the WebCAB. You can, again, interpret the client scores on the website, and that allows you to more quickly use this data to inform clinical interventions or adjust a treatment plan or clinical approach. Over time, after you've been using WebCAB for several months, then you'll really be able to start tracking assessments and see which ones have been given, how frequently they've been given, and understand, has there been change? What has the change been over time? And you can make a judgment. Oh, we need to change the clinical approach in some way, or there's some specific problem that the client is having a challenge overcoming. And also for programs, the data is always theirs. And so with just a click of a button, they can download their data if they wish for further analysis. Next slide, please. And then the benefits to states. I think this is also very important, and we'll hear about this, both the clinical and the state benefits in the discussion with Virginia. But especially if you choose to have all programs in a state submit data to WebCAB, and particularly if they're all using the same measures, then you'll really be able to see some amazing comparisons across your state. You not only will be able to see how many clients are being served and their characteristics, basically a census, you'll also be able to review all of the outcomes data, aggregated and at the program level, and especially over time, get infographic reports to review program data at a glance and changes over time. And so next slide, please. So we have here some examples from Virginia, and we can see here some of the census style data. At the top, we have on the left gender and on the right race, and we can see the percentage of clients across all Virginia sites of each gender and race. And then we can look let's say that's a program specific view, let's say, or no, it is at all Virginia sites at the bottom, of any legal issues in the last 6 months on the left, and hospitalized overnight in the last 6 months on the right. And particularly these bottom two, these were two measures that the state of Virginia elected to include and require that their programs collect. The top two, gender and race, are part of the demographics and would be collected by all programs, which in the next slide, we'll see. So the measures available, they're all the CAB measures. And so Abram already mentioned those 21 CAB domains. And if your program, or as a state, the programs you cajole into joining WebCAB, then every program collects client demographics and duration of untreated psychosis. And then the additional measures that are the choice of the state or program are over 35 measures across those 21 domains. There are baseline and follow-up versions for many measures. And so that's just, there's often a couple of questions that are different, one to establish the baseline, and then as you're following up over time. And so, for example, the demographics follow-up has significantly fewer questions than the initial than the demographics baseline measure, as there are certain changes that may not occur over time. And again, just to hammer home that these measures can inform clinical practice, and these measures can inform your policy priorities. And so, as Abram also mentioned there, oftentimes the states have slightly different interests in what they want to see measured than clinicians, and WebCAB can serve both those purposes. Next slide, please. So where can you go from here? If I've already sold you and you want to join WebCAB right away, then please contact us. If you want to learn more, we're plenty happy to discuss this more in depth and kind of talk through any specific situations in your state or in your program. And either way, please reach out to us. You have my email address right here, and you will, of course, receive these slides, mkazanjian@nri-inc.org, or endcc@westat.org. And that's the National Data Coordinating Center. And just to give a very brief description of what would happen if you reach out to us, what wheels get set in motion. The first thing would be, we would schedule a meeting with you, and we would discuss what WebCAB measures would be most appropriate for your goals. What are you trying to accomplish, and how can we help you with that? And if we then agree that yes, let's move forward, we would then reach out to all of the CSC teams in your state. If we had initially talked to a state, or if you are a CSC team that reaches out to us, then we'll skip that first step. and we'll find out who should be included in the WebCAB. We'll make sure they have access, and then we'll have a meeting with each CSC team individually and onboard them to WebCAB. And that takes about a half hour to 45 minutes. Periodically, WSTAT will provide reports using WebCAB data from across your CSC programs. Again, that's a tremendous advantages accrue if you get all of the programs in your state to participate in WebCAB. And WebCAB is always available to CSC, or WSTAT is always available to CSC team members to address any technical or data questions that they may have. And just want to add that we really are available for you. And if you have, for example, a team in Virginia had a new person join the team, and just yesterday did a quick onboarding for them so that they are comfortable using WebCAB. So with that, I will turn it back to Stephen. Thank you.
Ron, thank you so much. And we hope, many of you are getting a sense now of the value of the WebCAB for your state or for your team, and how it can really help drive the quality of your care and link your measurements to the broader national system. We're going to be moving to a panel discussion to learn from our colleagues in Virginia about the decisions they made to utilize this model, why they chose it, and what the benefits have been for them. Before we do, let me just say thank you to those of you that have put your questions in the chat. Please feel free to continue to do so. Given our timing today, we'll try to cover some of them directly through the Q&A responses in a written format. If we can't get to them all right now, we'll be glad to email people responses to your questions, but please let us know what questions you have, and we'll do our best to be sure we're able to address them one way or another. Next, I'd really like to introduce Dr. Howard Goldman, who's a professor of psychiatry at the University of Maryland School of Medicine. He's a mental health services and policy researcher and the editor emeritus of Psychiatric Services. Dr. Goldman's also a consultant to WSTAT and serves as the co-chair of the steering committee for the EPINET project, and he will introduce our panelists today and take us through our discussion. Howard, thank you.
Yeah, thanks, Steve. It's a real pleasure to be here today to host and moderate a conversation from some early adopters in Virginia. You've been hearing about Virginia and about the opportunities that the WebCAB presents. And we have three people from three different levels in the system in Virginia. And I'll introduce them very briefly. We have Jeff Van Arnhem, who's the Adult Mental Health Services Manager, who is the program lead for assertive community treatment and coordinated specialty care. We have Benjamin Marks, who's here. He's the manager for data analysis and evaluation. And we have Andrew Leonard, who's a senior family therapist and the team lead for the Navigate coordinated specialty care team in Southwestern Virginia. So if we can skip the slides and go right to the conversation. I want to give everybody a sense of how the whole enterprise in Virginia started. And by prior agreement, I was going to go to Jeff first because he appears to have been the instigator here. He was going to tell us a little bit about what made them get interested in WebCAB and how the whole thing proceeded. So Jeff, you want to lead us off here?
Sure, thanks, Howard. And it's definitely not the first time I've been called an instigator. Thanks, everybody. I appreciate you having us. One quick thing before I answer, Howard. Moran, next time we do this, we can be dark green for the Commonwealth of Virginia. We now have 11 programs that we support. So we're happy to report that.
Bravo, Virginia. Let's go, Jeff.
So from my perspective as a program manager for coordinated specialty care in the Commonwealth of Virginia, I see in our priorities as supporting, monitoring, and hopefully helping to grow high fidelity services that produce the intended outcomes for us. Obviously, to do this, we need data and we need a fairly easy way for our providers to enter that data and provide it to us without being too cumbersome on them on the front end. So enter the WebCAB into that situation. with the measures that we chose, we're able to, start to be able to observe trends, address any potential disparities, and hopefully improve services. And I would say lastly, the other thing we look forward to using the WebCAB for is for reporting purposes. We often have to report to stakeholders such as our state General Assembly. So we're hopeful that this information will be useful in that process going forward.
Yeah, I'm going to flip that over to Benjamin in a second, but I wanted you to go over sort of the fact that Virginia had an outcomes system. You told me that you had a system and it wasn't meeting your needs. Why don't you tell us a little bit about that?
Yeah, well, we used to require our programs to submit data to us quarterly on an Excel spreadsheet. Going old school there. So the providers were utilizing these measures, entering the data in a spreadsheet, sending them to our department on a quarterly basis. And it would be up to someone like Benjamin in his position to make sense of that data. To me, it was just raw numbers, answers to questions on instruments that I couldn't really do anything with.
So you find the WebCAB to be more useful to you?
User-friendly is probably the biggest thing I would say, yeah. Front end and on our back end as well, to be able to view and interpret the data.
Great. Benjamin, do you find this more useful to you than the previous, or you might have come to the system after that initial data collection process, if I'm not mistaken? But why don't you tell us how the WebCAB fits into your state data analysis procedures and functions?
Yeah, thanks for having me today, everyone. Yeah, so from a data perspective, it's an immense improvement, to say the least. So as Jeff mentioned, for a long time we had 8 sites across the state. Now we have 11. You get quarterly submissions across several years. You can imagine, you can do the math and figure out how many spreadsheets that is to go across and aggregate to distill outcomes from all of the state programming. Quite time consuming. There of course are some data reliability issues you might experience when collecting data via a spreadsheet. So there was lots of room for improvement, both on the quality side as well as the speed of analysis. And we also always try and think about the folks who are out in the field, like Andrew, our providers who are actually collecting the data. This is going into a web portal is much more systematic and easy. So all around, the data analytics process was very desirable, to assess data and extract information more quickly and show results across all of our state programs. And then I think
you have an example, Benjamin, of how you've used the data?
Yeah, so we have been tracking one of the outcome assessments we had prior to the WebCAB was the modified Colorado index that was mentioned in one of the core battery assessments earlier. We had that for a while, but we didn't have a way to readily look at pre and post information to quickly distill whether or not folks in treatment were actually seeking or seeing improvements in their quality of life and ability to function well. So that's been a great improvement, and getting away, I'm sure folks hear this all the time, from just getting data outputs, numbers served, to more of that outcome information where we can demonstrate improvements in individuals' lives is something we can now do a lot more easily.
So we've heard at the program level, from a state perspective, from Jeff, that it's useful for him as a program manager, and it's useful to you at the state level from a data management point of view and maybe from a policy level. But you mentioned Andrew. So Andrew's out there as the team lead. Why don't you tell us a little bit about how this system meets your needs
So
and
I'd like
what you
to-
like about it?
Sure, thanks, Howard. What I'd like to say is that I'll probably say at least once a week, maybe even more than that. Hey guys, we're doing a good job. We're really doing a good job in serving our participants. But what this does, this helps us really show that where we are with an individual, and we can tailor our services to that their needs. So think about substance use, housing, prior hospitalizations, employment, all those things that we collect that from the individuals. And then we can, I think substance use is probably a big issue. So we can go ahead and enroll them into a substance use program if need be. If they're looking for employment or education, we can help them with those pieces. So that it's really an effective tool for us to use.
So your perspective is as a clinical manager in the field. So are there certain items that are more important data items to you? And does that differ from what Jeff's looking at and what Benjamin is looking at?
I think the biggest thing are the modified Colorado and the quality of life, because we can look, are we really making a difference? Because it's really a very clear measure. And also on the other hand, if we see someone who has measured high on the modified Colorado, more severe, then we can make sure that they get the services they need. Maybe they need to be seen more than once a week in therapy, or maybe they need to be referred to crisis services or so forth. We know that right away by just looking at the scales.
Yeah, so if I can editorialize a little bit, this is really a learning healthcare system in action. This is showing how the WebCAB is used at various levels within the system of delivering first episode psychosis, CSC services. You're using it at the clinical management level, person by person.
Absolutely.
Jeff may be looking at one of the 11 programs and how they're doing. And Benjamin, you're looking at the state overall level, thinking about policies that might need to be changed, thinking about all 11 programs together. So that's a nice example. So we focused on the things that motivated your interest and that are going well. What have the challenges been? I imagine that there are ways in which it is challenging to implement a new system. And I don't know whether one of you wants to give us an example of a way that was challenging. Particularly great if you have a way you overcame the challenge, but there may still be things that are challenging now. Jeff?
Sure, I'll jump in. Howard, we're still pretty early in the process of utilizing, implementing the WebCAB. So knock on wood, thus far, no real problems. I will use that as an opportunity to mention one thing that we found helpful when you were talking earlier about, it was in the earlier slides, about maybe a difference between what state folks want to see and what clinicians want to see.
Right.
I think what helped us and what helped us get buy-in from our programs, from our providers like Andrew, was we chose the measures together. We basically met, myself, the providers, and with some consultation, we came up with, we agreed upon the same measures. So there was a give and take. And so I would say that that's a solution moving forward, or that might be helpful, I think, for other states, is to involve the providers in the process. Definitely improve buy-in, I mean, that was very helpful.
But have anything they want to add on another example, or?
I think one of the challenges that we've had early on is being able to get the participants to fill out the form, basically, and so that's been a challenge. We maybe have to knock on some doors, maybe use the tail end of one of their therapy sessions to do the measures, but we work on it. We do what we need to do as far as.
I'd never heard that one before. You find a good solution, let everybody know. That's always a challenge in these systems. I don't know, Benjamin, were there any challenges for you working with the data management advisory board I think you sit on that looks at some of these activities?
No, I mean, I would say the exact opposite. Usually when we're introducing a new data system, data requirements, we understandably get pushed back and want to make sure we, document everything appropriately for what's going to be changed and get it approved and everything. But we didn't really face that type of obstacle because this was a clear-cut answer. I don't think anyone's going to oppose going from quarterly submissions through Excel to actually having a systematic way of collecting it through a web portal. So that selling, the ability to collect data in this way was pretty seamless. And like Jeff said, we're still early on, so I might have commentary on the analytics down the road, but right now, in the initiation, it's been great.
Well, we'd welcome that feedback if you are having, structural problems with the WebCAB, with any of the items, and you have any feedback. To some extent, we're in the learning healthcare system with you, so feedback from your experience will go into other refinements. I just wondered, I don't know the extent to which this is true, but was it easier to get adoption of WebCAB items because they were vetted by a group of informed scientists and they came up with these particular measures as having good psychometric properties and being valid, having been used? Did that have any effect on the willingness to accept those items in the process where you decided what to use, what not to use?
I'd say, certainly utilizing instruments that reflect the evidence base is certainly a part of how we want to, implement services here in the Commonwealth of Virginia. So yeah, having those standardized, agreed upon, researched instruments that we know can demonstrate the outcomes that we want to see or show us areas where programs need improvement. That certainly helped us decide to utilize those measures.
Andrew, you're shaking your head. Is that useful from your point of view?
I agree. Yes, very much so.
Yeah, I know. In Maryland, we had an outcomes measurement system that took us years to develop, and it had input from scientists thinking about these services, and it still took us a long time to do that. So the WebCAB offers a shortcut for any state that said, oh, it would be really great if we had an outcomes measurement system, but how are we ever going to figure out what items to use and which ones are really good items and which ones are feasible? To me, that's one of the really great opportunities here for a state or a local program to adopt this. It's sort of a whole package.
Yes.
And you heard from Miran and from Abram about the support behind it. And we were just lucky we had this paper that Shoma Ghosh did the lead on, showing that state involvement seems to lead to better outcomes on the very measures that are part of the WebCAB. I wondered if there's anything, this is when we were supposed to stop this conversation, but we didn't have quite as much time. I just wondered if there's anything you wanted to add that I didn't ask you about, and we could go and see whether other participants in the audience have questions for you or any of the other speakers. I don't want to completely cut that short. Anything you didn't get to say that you'd like to add? I welcome it.
I think in general, overall, when we look at improving the quality of life with people who have psychosis, I think that's the big picture, and we're showing that now. I'm really proud of the work that we're doing.
It's a great enterprise, isn't it?
Yes.
We've been focusing for years on people who are already disabled. We made a commitment to that decades ago, but new services are now available for people in the early stages that improve their clinical outcomes. And it's great to see a data system that's devoted to that set of outcomes in use. Anything, Jeff or Benjamin, that you want to add? Or
I can't know other than to just sort of echo that it's hugely beneficial for us to have a means by which that we can see outcomes, and again, pretty easily with the WebCAB show outcomes, more importantly, to the folks, to various stakeholders who have an interest in it, on top of the benefit clinically that the program is providing. So it's an asset to be had.
Your enthusiasm is evident. We certainly hope it's also infectious. So with that, I think I'm going to make an executive decision here. We're a bit over our time, but we'll sort of share the shortfall with the question and answer group, and then see if we don't have any questions for these three folks from Virginia or the rest of our speakers. So it goes back to you, Steve.
Thanks, Howard. Really appreciate it. And thank you, Andrew and Ben and Jeff, for, your wonderful guidance and sharing with us, your wonderful experiences, the decisions you made, and your leadership around bringing this model to the state of Virginia. I think as we maybe move towards the questions, I think one of the, I want to actually ask first the one that was just raised by Janice Johnson in the Q&A. It's a very important question in terms of, how have young people with lived experience in terms of behavioral health issues been involved in the WebCAB with its development? Maybe, I don't know if you from Virginia could speak to the role of people with lived experience in terms of involvement around implementation, but could anyone maybe speak to us around that question?
I can tell you that there was input in the development of the CAB itself, even though the steering committee did not have in-person representation. Each of the hub PIs went back to people with lived experience in their coordinated specialty care programs and that advised their state agencies to help decide on which items to use.
So there was the involvement sort of at the more local level to bring back decisions about which tools. Yeah, okay, thank you.
I wonder whether at the level of the state, when Jeff told us that they sat down and they decided which items from the CAB to pick, I don't know whether people with lived experience were involved in that decision making.
To be honest, I don't recall everyone that was on the call. I was going to actually try and put my friend Andrew on the spot to see on the front line level, so to speak, if they are utilizing their peer provider on the team in the process, if that's helping some of the engagement issues that Andrew referred to sometimes.
Yes, we are. Yeah, we are using that. Yeah, using the peers to help us steer to go in the direction we need to go. Absolutely.
Well, thank you all. Thank you all very much for the answer to that question. And as Felicia has put in the chat, there are a number of questions that have already been asked and answered that are there under the answer questions in the Q&A piece. So please, everybody, take a look at those as well. Some of the questions that are still remaining outstanding really also have to do with some of the cost issues, the financial modeling, issues around the reimbursement related to Medicaid or private reimbursement, as people are looking at some of these issues around not, building out the programs more broadly. Just wondering if anyone can speak to any of those issues in terms of any of the financial aspects at this point that people are aware of, and how they might relate then to the utilization of data and the advantages of, clear data collection in a coordinated way to be able to make the arguments around the value of this care. Is that something anyone might speak to?
Sure, I'm happy to. That's exactly what I mean when we talk about the ability to report these outcomes to other stakeholders. The timing of us adopting the WebCAB has been very fortuitous because we're actually about to undertake a work group process that was required of our General Assembly to look at sort of a 5-year plan for coordinated specialty care in Virginia. And one of the things that we want to look at is the feasibility of a Medicaid reimbursement structure for this service. So again, I mean, the timing and the ability to have data show improvements, show outcome, hopefully be able to show cost effectiveness. These things are hugely important in advancing not just the clinical component, which is obviously the primary component, but to advance the coverage of this program and make it sustainable and attractive for other providers to grow the service. So the timing has been great for us.
Yeah, thanks, Jeff, very much. And I know, as we've been having meetings of our different financial work group around PEPNET, our colleagues in Illinois and Maine and Connecticut and California, as well as other states, are really finding value in being able to have that common data to be able to share as they're having discussions with commercial payers and developing models of care as well. So I think there may be real value for states in being able to utilize these common data collection systems to be making the arguments and showing the value of and the benefits of this model of care as well. So thank you all for that as well. One other question, just, if a state does want to adopt the WebCAB across their programs, do all the programs need to sort of be looking at adopting the same measures across the state, or is there flexibility from program to program, or how do they need to be doing that implementation if they're going to be looking at this as a state model? Abram, you look ready to jump in here.
I don't know if I'm ready, but I'll jump in.
Okay.
The WebCAB is purposely designed to be customizable. So it's really the option of the state and the programs how they want to handle this. You can, at the state level, decide that there may be a core set of items like Virginia's done that you want to implement across all of your coordinated specialty care programs, and you can then choose those, and that'll become your own personalized, customized WebCAB. But you also can customize it as a program and decide that these are the items and measures that you may want to adopt. So the WebCAB setup really has a pick what you like and what you want to use. We do have some general guidelines around all that, which aren't worth going into here, just to help the quality of the data. But you can definitely customize this to fit whatever your local needs are. That's we think one of the advantages of the WebCAB.
Well, thanks for that. I don't know if anyone else wants to speak to that.
Is it still okay to vary from program to program within a state which items are collected, or do we need a?
If that works for the state, yes.
Okay.
So it really is then a state decision as well. I guess I wonder if our colleagues in Virginia or anyone else could speak to, what it's been like in terms of rolling out this implementation. I know Andrew spoke somewhat about what it's been for you all, but as we're looking at different programs being asked to do this, do some of them get concerned that their data might not look as good as another program and have some hesitation to take this on? Or, what have been some of the issues in helping the individual programs feel comfortable sort of rolling out these measures over time?
Well, I hate to sound Pollyannish, but I mean, we didn't really encounter any. We have, I'm not trying to advertise our state here, but maybe a little. We have our providers are extremely invested. Again, came to the table and we worked on developing this core assessment battery for Virginia together. We obviously, if folks want to collect more, use all 35 measures, or they're welcome to, but we didn't want to go overboard. We agreed upon a standardized set that we think is going to be reflective of the work they're doing. States or providers, I know historically always have some issues about how are we compared to them. What we intend to do, is, and I think you might be able to speak to this better, but for providers to be able to see their, dig into their data, but see an aggregate of the rest of the state or ultimately others as well. So that sort of alleviates some of that and still gives people the ability to gauge where they're at in their services.
So they can independently do that comparison on their own and have a good feel for that then too. Okay, thank you. Well, we're coming to the close of our time together. And so, first of all, I just want to thank all of our presenters and all of our speakers for your willingness to share with us. And thanks for the wonderful panel and Howard for facilitating that part of the discussion. I want to thank our colleagues at NIMH and Samsa for their support and leadership for all of this work, and the Mhttc Network Coordinating Office for bringing us all together today as well. As you see on this slide right now, for a last few steps, in response to the funding we get, we're really asked to share feedback on learning opportunities that are being provided through our network. So if you could, before you log out, please, go to this brief survey that you see the link to about today's presentation, or which should be in the chat box for you as well. We'll try to put that link in there for folks, or use the QR code through your phone to be able to answer the questions as well. We'd really appreciate it. And also know that within a week, you'll be receiving a follow-up email with a link to the recording, the slide information, and then the ability to access your certificate of attendance. So with that, let's go to the last slide and say thank you to all of you for being here today. We're really grateful for your interest and time. And as you see there, if you're further interested in developing this in your program or state, please reach out to one of us. We really want to build this network and provide the support for all of you for the better care of the people in your community. So thanks again for joining us today. Everybody have a great weekend. Thanks.